And it's a pleasure to introduce our next speaker, Dr. Laurence Sperling. Dr. Sperling's been a great friend and advisor to the foundation over the years, and it's great that he could speak at this summit. I also want to verbally amend the bio in the summit program, so sorry about that, Larry. So Dr. Sperling is the founder and director of the Heart Disease Prevention Center at Emory here in Atlanta, where he's the Katz Professor in Preventive Cardiology and a professor of global health in the Rollins School of Public Health. He directs or has directed a number of unique programs at Emory, including the HeartWise Risk Reduction Program, the Intervent Atlanta, and Staying Aloft. And he founded and directs the first and only LDL apheresis program in the state of Georgia, and is the PI for the Cascade Registry here at Emory. He, as you learned this morning, was recently appointed, because he didn't have enough to do, the executive director of the Million Hearts Initiative at the CDC. Very, very exciting initiative, and really exciting to hear that he has taken that on. So today he's speaking to us about disparities in care in FH. He'll also be introducing our last speaker, a very special speaker in this session. So Larry, thank you so much for being with us.
Thank you, Dan, for that introduction. I'm definitely wearing many hats at this meeting here, and the most important hat, though, is representing patients who are living with FH, and I'll look forward to speaking with Mrs. Sandra Murphy, a very special individual. In the program, and the FH Foundation let me know, and I was very apologetic that they had in my bio that I was at Stanford University School of Medicine, and so I broke the news to my wife this week that not only did I take this new position with Million Hearts, but we're moving to California. So extending this real-world discussion, I'm going to focus on disparities in care related to FH. I have no conflicts related to my presentation. Importantly, what I express are my thoughts and not those of the institutions that I work for, work with, or represent. So as a broad overview, first I want to mention to you that there's little written or published about disparities of care in FH. And this is a great opportunity that we all have to both learn, to try to really focus on populations that may be at the highest risk living with FH. I'm going to give you an overview about disparities in health and health care because they're different. And then touch upon the available information we have related to disparities in FH, and then maybe leave you all with some challenges. So first, disparities in health and health care. We're here in Atlanta, Georgia. We're honored to be hosting the 7th FH Summit. And for those of you who are not wholly familiar with the city of Atlanta, we are very proud that we are the birthplace of the U.S. Civil Rights Movement. In fact, 5 miles from this conference center is the King Center, and also the Ebenezer Baptist Church, where Reverend King had his congregation. And this is a really, really potent quote from Reverend Martin Luther King. He said, "Of all forms of inequality, injustice in health is the most shocking and inhumane." We know there are clear disparities in both health and healthcare, and there's a difference. And we heard from the prior speakers in this session that these, in addition to the science and the technology and the implementation, remains a great challenge for us all in terms of caring for those at risk for cardiovascular diseases. In 1986, the Heckler Report highlighted that there are clear health disparities in those of racial and ethnic minorities. And these disparities are differences in quality that are not due to access-related factors, clinical needs, preferences, appropriateness of intervention. And also, we know there are clear disparities in those of various limited socioeconomic status and gender. We published this paper a few years ago, and this is the health disease continuum. And there's a couple of things I think we need to focus in on the health disease continuum. First of all, we as practitioners or clinicians, we're focusing frequently way out here, right? We're finding disease at a very late stage, and of course trying to make differences in the lives of these individuals. Very applicable to FH is finding states in a pre-disease state, because we've talked several times during this meeting about the New England Journal of Medicine paper from the Netherlands. Finding FH early and treating FH early equates to negating a potent risk factor. The last thing I want to point out is we really need to think more for all of those at cardiovascular risk, not just those living with FH, to have a better focus on health promotion and disease prevention. Well, how healthy are we in the US? Unfortunately, not very healthy. This is a behavioral and risk factor surveillance survey, 350,000 Americans from my now colleagues at the Center for Disease Control and Prevention. And unfortunately, only about 3% of Americans have ideal cardiovascular health. But many Americans are living with poor cardiovascular health, about 10% or even more. And there are great inequities among this population, disparities in age, gender, education, ethnicity, and geography. We published this paper last year in Circulation, and this figure from our paper says that we absolutely should be focused on preventing and treating traditional cardiovascular risk factors such as hypercholesterolemia. But very apart from the traditional risk factors are social determinants of health, which for many in our population are greater determinants of the risk for diseases than traditional risk factors. And the way we approach these social determinants of health have to be very, very different from the way we think about addressing traditional cardiovascular risk factors. So again, welcome to Atlanta. This is my home. What do we know about Atlanta? Well, we've talked in this meeting a lot about the power of genetics and genomics and metabolomics and et cetera. What we know, though, is not only in this city, but everywhere in the world where we live is a more potent determinant of health and disease than our genetic code, our zip code in this country. And so if we look at Buckhead, a northern suburb of the city, and drive 15 miles to Bankhead, west of the city, there's a 13-year difference in life expectancy. This is the city we're in today. And it tells us, as we think about it, we, in our cities in this country, have the equivalents of low and middle income countries right in our own backyard. Well, Mew and Curry talked a lot about the work they're doing in terms of precision public health and utilizing genomics to better the care as we focus on the right population and the right treatments and extending and partnering. And they published this paper which talked about implementation science to address health disparities in genomic medicine and highlighted that there are really problems in the high-risk populations and even those who are underserved. There are disparities, as several of our prior speakers have talked about, in the implementation and utilization of evidence-based guidelines, and there are clear barriers on many levels: poor awareness, knowledge, stigma, cost concerns. Several of our speakers talked about medical mistrust in medicines, in just general care systems, and limited access. And so we definitely need a multi-stakeholder approach to address the challenges we have with disparities. Well, what about disparities specific to the care of those living with FH? I like to use this very potent ARCIS slide just to look at our audience for a second to emphasize that although the FH Foundation has done miraculous work since 2012, really miraculous work, that FH remains hidden in plain sight. Now extend this concept to those living with FH who are living in areas where there's significant disparities and significant challenges related to health and disease. And this is probably the highest of the highest risk of populations living with FH. And that's really one of the main points I want to highlight. Well, it's likely that there are disparities among those with FH that are impactful, given that we know FH affects all around the world pretty equally, all races and ethnicities. We know women are diagnosed with FH at a later point in time than men, and that they have a greater rate of premature cardiovascular disease than their compatriots. The most understudied FH subpopulation, not only in this country, but I think globally, are blacks. And we have a great opportunity with the data sets we've talked about during the meeting to learn more about this population. The Cascade Registry, although it is ramping up and now over 6,000 individuals living with FH, it has fewer non-whites than we would expect by the US Census data. And it's unlikely that the prevalence of FH is lower in minority groups. Well, what is written about disparities in FH? There's not a lot out there. So again, I'm going to challenge this community to learn more, become more aware, focus on this population who may be at the highest risk. This is a great paper from the Cascade FH Registry. Probably several of the authors of this paper are sitting in the audience here today, over 3,000 individuals living with FH, and looking at disparities in LDL and statin use. As I mentioned, women are diagnosed with FH later than men. Women are also less likely to be on a statin or high-intensity statin and achieve an LDL less than 100 or an LDL reduction of 50%. Blacks are also diagnosed at older ages than other ethnic groups, and Asians and blacks remain less likely to achieve LDLs less than 100 or a 50% reduction of LDL. Well, the FH Foundation was gracious to share this more recent data with me for the presentation, and this more recent data that looks at disparities in LDL achievement highlights that they remain. So if you look at the most recent LDLs at follow-up, you can see that non-whites still have higher LDL cholesterols. Both of our speakers in this session touched upon health literacy as a covariate of disparities. And this is the only global paper I found related to disparities, if you try to search disparities in the care of FH, looking at 7 countries from 4 continents. And so health literacy challenges are common and not surprisingly relate to risk. And income appears to be an independent predictor of health literacy as an index of health disparities. Well, why are we here for this summit? Why are we engaged with this really, really important FH initiative, not only in this country, but all across the globe? It's because we're focusing on helping individuals and their families living with FH, and I look forward to speaking with Mrs. Murphy and her husband, Mr. Smith, right after my presentation. We've served at Emory as one of the sites for the Cascade FH Registry, representing the state of Georgia. I do want to mention Gina Lundberg, who's in the audience, is taking over as the PI of our FH registry at Emory, and so she's going to do great things. We know that. So we're here in Atlanta, we're here in Georgia. Let's focus in on the potential possibilities we have today to learn more about this population, probably at the highest risk. We've talked about Find FH, we've talked about Find FH heat maps. So let's take a deeper dive and look at the state of Georgia. So we're here in Atlanta, and what we can see, oops, I don't want to do that. There we go. What we can see is, here's Atlanta. And you can see a very dense, dark blue-green color around Atlanta, saying that the projections are that there are many individuals living in and around this city with FH. And this is looking at a 3 zip code level of data. Now remember what I showed the slide about zip code versus genetic code. And so how could we use Find FH to not only learn more about this high population at risk, but maybe focus on doing something about that? So I'm going to give you a future challenge in this country, but if you're from other countries, as you learn more about FH, focus on those who are living in a disadvantaged region, or those who have ethnic or social challenges and disparities, because once we find them, they may be the highest risk. So the future may be using FindFH and then tie that to the zip codes, because our zip codes predict health risk. And there we'll find probably those who need us the very most. I was introduced, I've joined the Million Hearts team. I'm very, very excited about serving in this role. Several from our team are here, and I look forward to serving you in this initiative. Million Hearts has a goal: preventing 1 million heart attacks and strokes in the United States. Focusing on keeping people healthy, optimizing care in those at risk, and focusing on priority populations, as I've talked about here during my presentation. I have been really fortunate to work with the FH Foundation. Catherine, amazing, since 2012. I see synergistic missions here between Million Hearts and FH, a clear, important partnership. And if we just do the simple math, 1 in 250 are living with FH, this represents over 1 million hearts. So to summarize my comments, there are clearly significant disparities in this country, but globally, related to health and disease, and what we see as delivery of health care. Similar disparities are likely in the identification and care of those with FH. We need more data to better understand the impact of these disparities and the impact on the outcome of those living with FH. And this is a really important take-home, is approaches to addressing traditional risk factors, because that's what we've been really focused in on, are very different and should be coupled with interventions to confront health inequities. And I'm going to close with another quote from Martin Luther King, because it's very apropos to this dedicated, passionate audience here. He said that human progress is neither automatic nor inevitable, but will require tireless exertions and passionate concern of dedicated individuals. You are a group of dedicated individuals. I thank you very much for your time and attention. We're going to have